So, hi everyone. Anna Maikes, the CEO and founder, and I want to welcome Jazmin, Beth, and Alex for for this kind of session. I think it's amazing that they can talk to us about something like addiction. As a company, as you know, we are very focused on both EEG and brain stimulation, and mental health is very close to our heart. I have to tell you that the more 100 people that we have in the company are strongly devoted to help patients in need and move the science so that really we can help a lot of people suffering. So first of all, thank you for your work. We really need good science and good studies to push, in such a difficult area as addiction. And thank you for really, joining this seminar and helping us to spread the word that there are different ways to treat diseases and that at the end science wins. So I leave you with JT and thank you again for your wonderful work.
Thank you so much, Anna. Hello all and Happy New Year. Thanks for tuning in today. I'm JT Vanna, your host for today's panel discussion, and I'm thrilled to introduce our first topic of this series, Resolutions That Last, NeuroTech Conquering Addiction. This program is part of a composite in celebration of 10 years since opening our Boston office. To hallmark that milestone, we've created quarterly virtual panel discussions focusing on mental health topics, as we see it, the future of psychiatric solutions. Today, we kick off the first of the series, NeuroTech Conquering Addiction, followed by our spring topic, EEG as biomarkers. This summer, we'll look at brain health gets moving with NeuroTech, and next fall, suicide prevention by adapting brain circuitry. Regarding today's topic, it seems year after year, individuals make resolutions to overcome addictions, but the journey is often challenging, with relapses occurring during the lengthy process of physical recovery in the brain, often over a year. Today, we explore innovative approaches to reaching lasting recovery. We have the honor of being joined by 3 distinguished speakers who will share their expertise on this critical topic. Let's introduce our speakers in the order of their presentation appearances. First up, we have Ms. Beth Huey, Clinical Director of the Recovery Centers of America in Danvers, Massachusetts. With 10 years of experience as a licensed mental health counselor, Beth specializes in severe and chronic mental health, including addiction. She has been instrumental in managing mental health programs and is currently leading clinical in- and outpatient services at the RCA in Danvers, Mass. Next, we welcome Dr. Alexander Danvers, Director of Treatment Outcomes at Sierra Tucson in Tucson, Arizona. Dr. Danvers, a psychologist with expertise in mobile sensing, machine learning, and psychophysiology, has contributed significantly to the field through his work on measurement-based care and applied neuroscience programs. Our third speaker is Dr. Jazmin Camchong, an assistant professor and cognitive neuroscientist at the University of Minnesota. Dr. Camchong's exciting research focuses on effective clinical and non-invasive interventions to support recovery from substance use disorders, with emphasis on neuroimaging studies. Following the presentations, we will engage in our panel discussion where our speakers will provide next steps and will address questions. Thanks again for joining us today as we embark on this journey of exploring resolutions that last and NeuroTech's role in conquering addiction. We look forward to a fruitful discussion and collaboration throughout 2024. Let's make this year a transformative one for mental health. Now, without further ado, let's hear from our esteemed panelists. Each speaker will share insights into conquering addiction through innovative approaches in NeuroTech. Beth will kick off our presentations with fundamental information on addiction, followed by Dr. Danvers and Dr. Camchong. Ms. Huey, the virtual stage is yours.
Thank you so much, JT. All right, so I just wanted to go through first, thank you so much for inviting me, JT. It's very exciting to be able to talk on a larger stage about this topic. It's a very sort of hidden topic in a lot of ways. And so I'm really excited to be able to cast a little bit of light on this topic and this population. So like JT said, I am the clinical director of both outpatient and inpatient services for the Recovery Centers of America. And just a little plug, Recovery Centers of America in Danvers was named the best treatment center for addiction in Massachusetts this past year by Newsweek. And we were 16th in the country, so very exciting. So we are doing some good work here. Our goal is, of course, to save lives. And here in Danvers, we have 3 different prongs to our treatment approach. And I've put them up on this slide. So we first have acute treatment services, which is also called detox or MMW, medically managed withdrawal. And that, of course, is led by our nursing and medical team. Case managers are on site to begin any of the aftercare process that needs to start. And we provide a lot of psychoeducational groups to really normalize some of the process. Patients then move to crisis stabilization services, which is our residential treatment. Ideally, they're with us for a total of 30 days across ATS and CSS. And in CSS, we can step things up a little bit more clinically. Our clinical team directs that area of service, of course, supported by medical and nursing as needed. We work right away on a continuing care plan. There's a lot of good evidence that the longer a person stays in treatment, up to 90 days, the better their recovery outcomes are. So we focus on individual, group therapy, as well as family therapy to incorporate everybody in. And then, of course, we have our patient services. So outpatient services are designed to sort of step away support as we go. Partial hospitalization is 5 days a week. IOP, intensive outpatient program, is 3 days a week. And then GOP is 1 day a week with some individual counseling as well. So this just sort of gives you a sense for what the standard of care sort of looks like right now and what we're doing here at Recovery Centers of America. But I want to zoom out even farther and talk a little bit about what addiction is. So the American Society of Addiction Medicine defines addiction for us. And so I'm going to go ahead and read a part of that definition because I think it's really important and relevant. And you can see I've highlighted some pieces here. So the definition of addiction is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experience. And I think what's really relevant about this is this description of addiction really frames it in that medical model. It really reduces a lot of the stigma that is associated with substance abuse. You may have heard, people say once an addict, always an addict. And there is some truth to that, but it is a treatable condition where individuals can go into remission and in recovery, and then may have a reoccurrence of their disease, which is what makes this a chronic illness. And there are lots of other chronic illnesses that we would describe in a very similar way, but are not stigmatized in the same way that substance use is. And we'll circle back to stigma as a major challenge in the treatment of this disorder as we move through. Anyone who uses a substance use disorder is at risk. However, there are specific markers that make you more likely to develop a substance use disorder, starting with early onset use. This is for a variety of reasons, and I won't even begin to get into the brain science. I'm going to leave that to the other speakers. But early onset use before the brain is fully developed can cause a significant impact with younger people. As we know, our brain isn't fully developed until we're in our 20s. So that use can have really lasting impacts and can develop a stronger addiction. Of course, genetics and gene expression. And this is a big one that, a lot of people don't know about and are very surprised to hear about the strong genetic component. And that, this is often something that, a person may be predisposed to with or without knowing that. And then, of course, the last one is trauma, particularly adverse childhood experiences. I usually say that all of our patients here at RCA have some form of trauma. The vast majority, that's trauma pre-addiction, something that went on in their childhood, often, as time has gone by, that's the way that they have been ameliorating their disease is with substance use, or ameliorating their trauma is with substance use. But additionally, I always say that having a substance use disorder in and of itself is traumatic. These individuals are being estranged from their family. Often they're going to prison, they're being arrested, there's car accidents, there's all kinds of things that can really be traumatic. So a lot of that contributes. So who has a substance use disorder? This is a highly prevalent problem that we have right now in our country. So about 48.7 million individuals were diagnosed with a substance use disorder. This data is from 2002 from the CDC. That's about 17.3% of the population. So we can see that this is a really enormous problem. Of that group, only about 24% actually received treatment in the last year. And 40% of that group were adolescents. 16.4 were between 18 and 25, and 24.7 were 26 and older. So we can see that right now there is a very strong focus on providing treatment to adolescents and young adults, which is great that we're shining a light on that. But that's not the only area that we really need to continue working. I also put up this Venn diagram that illustrates individuals with an alcohol use disorder, individuals with a drug use disorder, and then the combination. You can see that alcohol is, a very large percentage of substance use disorder. Obviously, access is a major factor there, but there is a sort of growing drug problem. And so it almost looks like a 50-50-ish split. And so we'll talk a little bit more about how some of those drugs are growing. So for alcohol use disorders, you can take a look at past alcohol abuse in the past month. And we can see by age where the problem primarily is. Usually that problem is, in that sort of mid-range of 18 to 25. And I just want to sort of identify that binge drinking is drinking multiple drinks at a time. For males, I believe it's 5. For females, I believe it's 4 at this point. And heavy alcohol use is considered weekly use. So if you're having, I believe it's between 50 and 40 drinks a week, which is quite a bit actually. But we have a very large percentage of individuals that this is how they're dealing with a lot of their substance use. And I would be remiss if I didn't mention that we just went through a pandemic, which significantly isolated individuals and caused a major uptick in alcohol use across the country. This map, you can sort of see the prevalence of use. You can see that the middle of the country has a higher prevalence rate, but it is still fairly ubiquitous. We are seeing a lot of alcohol use across the board. So alcohol use is about 60% of drug use, or of our substance use disorders, and illicit drug use is about 40%. So if we look at that, 70.3 million individuals have used illicit drugs in the past year. That doesn't necessarily mean that they have a substance use disorder. Substance use disorders are marked by a lack of control over the use. And there are individuals who use recreationally or who are trying it out for the first time. You can also see this chart on past year initiates. So you can see that nicotine and vaping, of course, is the #1, but marijuana has become a very high rate of use. That's likely similar to alcohol. It's becoming a lot more accessible. And so certainly more individuals are trying it. Certainly also as it's become more accessible and legalized, people are less concerned about the impact that cannabis may have on them. So they're more inclined to try it out. I think it's also important to note that a lot of the drugs that are listed on here are prescription misuse. So that is a growing area of concern. So if you look here, we've got prescription pain relievers, prescription tranquilizers, and or sedatives. That's usually our benzos, benzodiazepines, Ativan, Xanax, Klonopin, and then our stimulants, which are used for Adderall or for ADHD medications. So more than 2.9, there we go, million people misused these prescription drugs, these controlled substances in the last year, which is really a significant amount of individuals. 17.6 in the past year, and 2.9 have initiated with that use. So it's a pretty significant problem. I want to mention that here at Danvers, we reflect that percentage. We actually have about 60% of our population comes in with an alcohol use disorder, and about 40% come in with a illicit drug use disorder, and the vast majority of those are opioids. So I wanted to really touch on what is fast becoming a opioid crisis in our country. 8.9 million people misused opioids, including heroin. Only 1 million heroin users. So you can look at this Venn diagram and see that the vast majority of opiate use disorders are not heroin based. These are people that are not going on the streets necessarily. And we can see in this other Venn diagram where people are getting it. They're mostly getting it through their healthcare provider, through either legitimate prescriptions or stolen prescriptions. They're getting it from friends and family who have prescriptions. So again, we're seeing, I feel like a broken record, but accessibility is a huge factor in whether or not these drugs are being abused and addiction disorders are being developed. So I think it's really important to mark that. I also wanted to mention that from 2021 to 2022, heroin overdose deaths actually decreased by 32%, which is fairly significant. However, overdoses from synthetic opioids, so those prescription opioids, is continuing to rise year after year. So we're seeing, one area drop, but the other area really is expanding. So that's a significant concern. So jumping into sort of the outcome of all of this, which was overdose deaths. So I did want to mention that alcohol, excessive drinking also contributes to deaths. However, this is illicit drug overdose deaths. But excessive alcohol contributed to 140,000 deaths in 2023, and 40% of that was due to binge drinking. So the other 60% is, the detriment that alcohol can do to your body. It is particularly difficult for the body to sort of process that long-term and chronic use. The charts that you have in front of you are overdose deaths that are sort of generally related to drug overdose. In 2022, overdose deaths were at 106,699 for the United States, so a fairly significant amount. This has increased 5-fold in the past 2 decades. So there is a rapid increase of this very significant issue going on. Overdose rates have increased by 14% from 2020 to 2021. In males, that was a 14% increase. In females, it was a 15% increase. The highest rates of overdose we see between the ages of 35 and 44, and adults 65 plus had the highest increase in overdose deaths, with a 28% increase from 2020 to 2021. Again, I want to emphasize our older adults are not able to access street heroin and those kinds of illicit drugs as easily as they're able to access prescription drugs. So that may account for some of the increase in overdose deaths with that population. Again, the biggest increase in overdose deaths is synthetic opioids, particularly fentanyl. Fentanyl has become a significant problem, I know, for us here in the Northeast. We actually distribute Narcan to all of our patients, and I'm often asked, why would you distribute Narcan to someone who comes in for an alcohol use disorder? Well, one, Narcan is always good to have on hand just in case there's an emergency. You could save someone's life, so that's a positive. But I also always let people know that right now in New England, if you are buying illicit drugs off the street, they very likely have fentanyl in them. no matter what they are. Even if that's cannabis that you're purchasing outside of a dispensary, they will likely have small doses of fentanyl in them, which makes them incredibly dangerous. And if you are opioid naive, even a small amount of fentanyl can lead to an overdose death. So it's fairly significant. Cocaine overdose rates increased by 22% from 2020 to 2021. So that's also fairly significant. And prescription stimulant overdose increased by 33%. So again, it's that accessibility. The more that we are increasing the avenues for individuals to access these substances, the more likely these substances are to get a hold on them. So I would be remiss if I did not speak about substance use and mental health disorders. So as JT had said, part of my specialty is adults with severe and chronic mental illness, and that includes addiction as a severe and chronic mental illness. We can also see that individuals who have substance use often cross over with individuals who have a mental health disorder. So you can see in those Venn diagrams how some of that breaks down with any mental health disorder, and then with serious mental health disorders, which are more of the disorders that I particularly work with. And you can see that there is about almost a 50% likelihood that if you have a severe mental illness, that you are participating in some kind of substance use disorder or substance use. You can see on the chart that those red lines there are individuals with serious mental illness, and so they are always at the highest likelihood for engaging with substances. And this, of course, increases rates of suicide. It makes suicide more accessible through overdose. When individuals with a substance use disorder are engaging in that substance use, they're also very, very vulnerable to their impulsive thoughts. They're vulnerable to their symptoms. And so we're more likely to see their symptoms become very, very serious in the context of substance use. So this is a huge issue and something that we really need to stay very, very focused on. I did want to talk a little bit about treatment models. So 84.2 million adults with substance use disorders and any mental illness. Oh, here we go. These are the stats that you're looking at. So serious mental illness can be highly correlated. And one of the ways that we treat this, both a substance use disorder and mental health disorders, is we use a lot of the same treatment models. So we use a lot of psychoeducation to normalize the disease, to explain what symptoms can be expected from the disease. Just because someone is diagnosed with a substance use disorder, it doesn't mean that they know very much about that substance use disorder. They may not know how it developed, what things they need to work on. And again, since these correlations are so high, often, and we talked about in the beginning that, with trauma, there is a much higher likelihood of substance use. Knowing how to break down that trauma and how to be able to find alternative coping skills to alcohol or drugs is a major factor. So providing that psychoeducation can be really seminal. We also, of course, use cognitive behavioral therapy. It's one of our sort of mental health bread and butter tools. Cognitive behavioral therapy is an evidence-based practice that links our cognition, our behaviors, and our feelings together, and sort of explains how they work together so that individuals can begin to harness control of some of their behaviors. So that can be very, very helpful with a substance use disorder in identifying what thoughts lead to those use behaviors. In addition, dialectical behavioral therapy has become more popular with substance use. Dialectical behavioral therapy was originally designed to work with individuals with borderline personality disorder. It was actually developed by Marsha Linehan, who was diagnosed with borderline personality disorder and was told, there is no treatment for this. And she said, no, I don't think so. So she wrote her own treatment. And the amazing thing about DBT is that it's very direct, it's very straightforward, and it's very concrete. So it's easy for patients to grasp. We've now generalized this treatment, and it can be incredibly useful for our substance use patients because it really goes into the sort of detail of how to develop coping skills that are going to be best for you, and how to use mindfulness and knowledge of your own mind and your own thought process to stop behaviors and to change the way that you react to the world. So it's a very useful tool. And last but not least, one of the big tools that I definitely need to mention is motivational interviewing. Motivational interviewing is a tool that we use to capitalize on individuals' ambivalence. And a lot of our substance use patients come in with a huge amount of ambivalence. Their body and their mind is telling them that they need to keep using to survive. And then all these other things in their life are happening that tell them they need to quit. So they're very ambivalent, and being able to steer them gently in a way that allows them to come up with their own reasons for quitting, and sort of gears them back towards that side can be incredibly helpful. But it's a technique that you need to be very skillful in using. I wanted to talk about a few challenges, and I know I'm sort of going a little bit long, so I'll wrap up here. Some challenges with treatment. First is recidivism rates. Readmission rates for substance use disorder are around 25%. That's where we are here at Danvers as well. Readmission rates for mental health disorders are about 13%. So you can see that with a substance use disorder, you're more likely to have to return to treatment over time. There is a lot of difficulty with calculating recidivism rates, because some patients will jump from provider to provider, and it's difficult to track some of that. Some patients also choose not to use their insurance, and that's a way that we often track those reoccurrent rates. So that can sort of be challenging in getting some of the statistics. Some other challenges are that in America, we primarily use an abstinence model, and this may contribute to some additional overdoses, because if you've been abstinent for a period of time and then you go back to what was your regular use, that may result in an overdose. So having an abstinence model can be effective, but a lot of places are moving to more of a harm reduction model, so that we can work with individuals who are having trouble with that complete abstinence. And of course, the stigma of mental health and substance use disorders is a huge challenge for us. There is stigma even within providers, within therapists, physicians, towards this population. So it can be really difficult to get buy-in from providers to be willing to see this population, and to really be willing to work with them with compassion and care. But that is clearly what is needed right now. So my references, you can see I use a lot of the CDC, and some other areas, but that is my brief little synopsis on what is going on with substance use here in this country.
Yeah, so my name is Alex Danvers. I am the Director of Treatment Outcomes at Sierra Tucson. And what I'm kind of hoping to do is maybe talk a little bit about how I've been thinking about, and how Sierra Tucson has been thinking about bridging between the types of problems that Beth was just describing, because we are a residential mental health treatment facility. We deal with addiction, although that's not the only thing we deal with anymore. We think we now actually have around 40% folks who are here for trauma recovery. But certainly what we're known for is our rehabilitation services. And what we've been doing in recent years has been trying to apply neuroscience and some of the new emerging modalities to build kind of a applied neuroscience or clinical neuroscience program that can be an adjunct and help our clinical decision makers give the best possible care to our patients. So just a brief overview. We were founded in 1983. We are out kind of in these beautiful mountains in Tucson, Arizona. I'm actually also from the East Coast, but it really blows me away every time I drive up and see the mountains on the way in for my commute. We have both inpatient and residential. We have a PHP and an IOP program. Beth actually did a really nice job of describing the model that they use at Danvers, and we use something very similar here at Sierra Tucson, where we'll do kind of this acute treatment at the inpatient level and have people step down into a residential level. And we are a JCO accredited facility. Our core programs are addictions and co-occurring disorders, complex and chronic pain recovery, mood and anxiety disorders, trauma and PTSD recovery. You know, the addiction is probably the most relevant for this particular talk, but I will mention that we see a lot of the kind of overlap that Beth was just talking about, where folks come in for chronic pain and actually it's related to their trauma. Folks come in for addiction and they also have some mood disorders. So we try and make sure that we do put people in specific programs, but we have a lot of crosstalk between professionals to make sure that we're giving the best possible care. We also kind of have this integrative model where we do a lot of what we call sort of extra or experiential therapies. We do adventure therapy, we do EMDR, equine, somatic experiencing, and kind of at the bottom, I'll be talking a little bit about our bio and neurofeedback. That's a program that I am a manager for. When I was hired at Sierra Tucson, it was really more to be tracking and doing statistics and research on our outcomes. But the other piece of it was also to run this applied neuroscience program. This program has been around for several years, but I've only been at Sierra Tucson about a year and a half now. So I'm starting to kind of put my own mark on it, and I've got some ideas about what to do with it, and sort of hopefully what this presentation is an opportunity to share some of my thoughts about where applied neuroscience can go in a residential mental health facility like this. So just the kind of brief overview piece here, we do this applied neuroscience program where we bring people in and they have different sessions they can take with us. And I'm kind of divided between the central nervous system and the peripheral nervous system. The peripheral nervous system is addressed through heart rate variability biofeedback. To folks like me who worked in a psychophysiology laboratory in grad school, we know that HRV is a really big clinical indicator. It's related to a lot of important psychological constructs like emotion regulation, negative affect, and things like that. So we do a little bit of treatment on that. The treatments we have for the brain, I would kind of split in two directions. One is transcranial magnetic stimulation. TMS is a really strong and effective treatment for treatment-resistant depression. That's what we've been using it for here at Sierra Tucson for about 7 years. We were the first facility in the US to get a TMS machine. And we have just recently upgraded from the kind of standard TMS to having theta burst, which allows us to give our treatments in a much shorter time. We used to book out like, 21 minute session. Now it's, 3 to 5 minutes of actual treatment. So it's much quicker. We can get more folks in. I'm not going to talk about that as much here. I just wanted to mention it because that is really something that falls a little bit under me, but also under medical. So a medical provider can recommend it for treatment-resistant depression. There's some other indicators that it's been FDA cleared for, and there's obviously a lot of ongoing research on what it can be used to treat. And so we're also working to expand our offerings in that area. The next piece, and this is kind of like the mid piece here, this QEEG bit, is a quantitative assessment of the EEG data. This obviously fits really well with what NeuroTech is doing. This is recording people's brains, scalp electricity at rest. This is sort of classic eyes open, eyes closed, do something simple like counting, and then we measure frequency band information. We use that to inform what other treatments we might use for that person in the applied neuroscience department. So we use that to guide neurofeedback, audiovisual entrainment, and transcranial direct current stimulation. I'm sure that Jazmin will go over this in much more detail, so I don't want to talk too much about TDCS, but this is a method that obviously is built into the NeuroTech device, and I think something that we've looked into expanding our program on. Right now, we consider ourselves more like we're doing education on neuromodulation, And typically, patients who are interested will get something like 3 sessions, and they'll try a mix of different modalities, including transcranial direct current stimulation. This is actual direct electrical stimulation of the brain. It's a lot less intense than TMS. In fact, a lot of devices are sold for, kind of home use. And it's thought to induce neuroplasticity. When I took over this department, I went through recent clinical guidelines and found that there were a couple of recommendations for specific clinical uses that were relevant for us. So this 2021 FREGNI guideline found that this is definitely effective, or level A for depression, and level B for pain and alcohol craving relapse, which, as you'll remember from the 4 things that we treat, that's 3 of the 4. So that puts us in a pretty good place to want to introduce it to our patient population. We also have, as I mentioned, a pretty substantial trauma program. And so we've looked up some recent research on using TDCS for PTSD. And it looks like there are some protocols and there are some trials that have shown some effectiveness. Right now, what we're looking at is some trials that show the dorsolateral prefrontal cortex as being targeted, and some ventromedial prefrontal cortex. And the way that I've seen them kind of described, big picture in the literature, is that the VLPFC really hits kind of emotion regulation and executive function and extinction learning networks, and then the VMPFC hits inhibition of threat responding, and also hits extinction learning. So, obviously in a PTSD scenario, kind of exposure and processing of trauma is key, and we think both of these sites might be interesting, and we hope to kind of follow the research as more comes out on whether there's one that emerges as clear favorite, or whether there are other clinical indicators or indicators from something like the quantitative EEG that could help us make the decision of which site to target. So I think I'm kind of going through the overview of Sierra Tucson really quickly. And that's kind of because I was excited to share with everyone here today the start of our new neurofeedback, but really, I guess we should call it a neuromodulation treatment program. So up until recently at Sierra Tucson, we have, as I said, primarily been doing kind of an educational and sampling approach to neuromodulation. So it would be typical for somebody to get a QEEG brain map, get some information about themselves. That's always going to be paired with our standard care, where they're getting validated, psychometrically validated clinical assessments, where they're doing sort of the standard things that you might assume from a measurement-based care program, getting their anxiety, depression, PTSD scores from instruments. But then they also have been getting these brain maps, and then they would get 3 sessions where we kind of talk through, okay, this is what the brain map is showing, this is what you're presenting with and what you'd like to work on, and we make a decision about what might be an interesting modality for you to explore. They can always purchase longer packages, like extra sessions kind of to lengthen their treatment, but typically it would just be kind of like, okay, now you've learned about this. If you want to go out into the community, if you want to buy a device, some of these have home devices, what works and what doesn't work for you, or what direction you might want to go to. The new applied neuroscience treatment package that we're introducing involves a QEEG brain map at the front, 10 sessions, primarily of neurofeedback, and then a QEEG brain map at the end to see changes in brain functioning. And the big difference here being that we're really hoping to get closer to a full treatment course in. One question we get out from a lot of our residents is, hey, is 10 sessions enough? Do I need more? Do I need less? 10 sessions is probably on the low end when you look at different clinical trials for neurofeedback, but it is on the high end of our scheduling feasibility, and it is within a range where we think it will have some clinical efficacy. And then certainly if they need to continue, we can make recommendations to other local providers that we know. So the details here on our neurofeedback package on the side here with the 1, 2, 3. This is exactly what I just explained. We have our baseline brain map. We have our 10 neuromodulation sessions. Then we have our our EEG post brain map. The primary modality that we're trying to use here is neurofeedback. This is a form of biofeedback where you're literally getting information about your brain's activity while you're sitting there. And the idea is that it uses operant conditioning to try and train somebody to change their own EEG activity, right? So this is electrical activity that's captured at the scalp, and we have a clinical database that we use that provides certain norms. And as you put yourself in a sort of mental state that leads to the change in EEG that corresponds to a normative value, a value that's no longer outside the norm, because we target it based on that brain map. That brain map's going to say, oh, when you're at rest, this alpha band is maybe a little bit out of normal range, or this theta band is a little bit out of range, or a theta beta ratio might be out of range. And so we would train to try and have the person be able to bring their brain back to a state where that is in range. For the patient, it feels kind of like they're playing a video game. We use something called Zupor's Air. They're flying like a dragon or a jet or something through a series of rings, and as they bring their brain into the right state, the animation puts them through the ring, and as they get away from that state, it slows down and they're not going through the rings. So from the perspective of the patient, it's kind of a little bit weird because you can't really tell them, hey, this is exactly how to get your brain in the right state, but it also is kind of this like live real feedback, and I think they kind of pick it up intuitively from watching what they're seeing on the screen. So as I mentioned, this is brand new. What I've had my colleagues who worked on this very first neurofeedback package participant or patient, I guess, do is kind of like make this case study, and we've talked about it together, and I'll thank them at the end, but thanks to Allison Bell and Riley King for doing this first case. This is a patient who sought treatment at Sierra Tucson for trauma, for mood problems, and substance use disorder. So it's our big trifecta here. They got their QEEG brain map results, and then sort of Riley King, who's our neuromodulation practitioner, will sit down with that person and say, hey, these are the things that seem out of the normal value. These are symptoms that are associated with it. Do these kind of, first we kind of check, does that make sense to you? Do you think that rings true given your experience? And is there anything here that you'd really like to work on? And this person really wanted to work on their attention, their executive function, and then some symptoms of anxiety as kind of top priorities for their treatment focus. We use a database and QEEG output designed by Dr. Paul Swingle. He's a practitioner out of Vancouver who has contributed to neurofeedback quite a bit. We also have his books here in our office, so we encourage our staff to read them. We recorded at locations O1, CZ, F3, F4, and FZ. And here's kind of the clinical presentation. We saw an elevated low-high alpha ratio, which can be associated with memory problems or difficulty concentrating. We had issues with frontal beta balance, which can be related to anxiety. We had a low frontal beta alpha ratio, which is difficulties with executive functioning. We had a frontal theta beta imbalance, which is associated with difficulties with emotion regulation. CZ was ultimately the location that we ended up targeting. There was a large theta beta increase under task. So when we went from just sitting quietly to starting to do some counting, and that's often associated with attentional problems. Theta beta ratios are often trained for ADHD patients. And because this is what the patient was like, this is really what I want to work on, we said, that sounds great. The nice thing about our applied neuroscience department is that we're part of a bigger team. So we know that there's a psychiatrist, there's a primary therapist, there's a specialty therapist, and all those people are treating this person, and we're coming in kind of as an add-on. So where we can add benefit is going to be where we're going to try and fit into that treatment picture. And just to finish the clinical Q remarkable values, there are also some issues with theta beta ratio at 0.1 over the occipital lobe, which can be related to stress and sleep difficulties. So this is an overview of the 10 sessions that the person got. I want to highlight first that they mostly got neurofeedback sessions. We allowed that person to kind of like give us a little feedback on what was working. This is, our very first time going through this. There were definitely some days where this person said, the neurofeedback is exhausting. I don't want to do that today. Is there anything else we can work on? So we had these 6 sessions of neurofeedback, and they were all kind of working on this very specific theta beta ratio at CZ, kind of in the middle, on the top of the head. But then we also included some TDCS treatments in the middle there. And so by kind of leaving that in, interweaving the different modalities, we were hoping to ultimately get a good effect that we could see in the post-treatment QEEG to see changes. So here's kind of a typical way that things would go in a session. We would have them take a baseline of the theta beta power at that particular location that we're training, and then we would have them do 5-minute rounds of neurofeedback, because it's kind of tiring and you want to take a little breather in between. And then you can see kind of this is the average theta beta ratio, at baseline, and then after a little bit of training it goes down, but actually the person can end up getting tired. And so in any given session, it might kind of bounce up and down a little bit. But when you look at the difference between session 1 and session 10, you can see this reference line is kind of the clinical norm. By session 10, they're pretty consistently able to keep it at or below the clinical norm, which suggests that they've actually, not through any kind of direct intervention, but kind of partially through their learning and their training, they have learned to put their brain in this healthier, more sort of attentive state. And then if we wanted to look across the different sessions where they got neurofeedback, we can see, this is real data. I think if I were to show this data to somebody who I was trying to maybe sell on the program, I would be really thrilled if it stayed consistently low. But, there's a little bit of bouncing up and down, but once the baseline got below the clinical norm, it stayed below the clinical norm across all the training sessions, which we think is really helpful. And then finally, we can kind of look at here, at the beginning, I was saying, hey, these are all these remarkable ranges in the clinical QEEG. What's changed? And we can see that, for example, the high-low alpha, the norm is between 1 and 1.5. Pre-treatment, it was 1.57. Post-treatment, it's 1.14. So we would say, yes, it has improved and it's moved to being in range. This was really the area the person wanted to work on the most. This CZ change, we saw some improvement, but it didn't move down into range. One of the things that's interesting here is that we're seeing across all of these, even though we just trained at one location, the brain is kind of a flexible, adaptable organ. Changes in, it's kind of a regulatory system. It's not like a, sort of metric abacus system. The different changes in one area are going to lead to compensation or changes in another area. So we did see improvements in the majority of the areas that were remarkable, and actually several of them went back into sort of a normal healthy range by the end of the treatment. We also can look at this person's PCL5 scores. PCL5 is the post-traumatic checklist for the DSM-5, and look at their change over their course of all of treatment, right? So this is not a brain measure. This is a measure of, what was the treatment effectiveness? Everything has been scaled from 0 to 100%, based on how high they could possibly score on the scale. Over the course of their treatment here, we did see that a lot of their PTSD, actually all of their PTSD symptoms did decline considerably. In some cases from like 100% feeling avoidance to 0%, or from 75 having intrusive thoughts to 0%. So that was a nice change that we saw for this person. Finally, we also collected information on depression, and in our depression scale, we know that problems with focus is one of the 9 symptoms that's most typically assessed. And so I just kind of like clued in on that one to see if, because that was what he wanted to work in, he felt like he was having effective changes, and it looked like he was seeing some effective changes. They came early and it kind of stayed low. So I would say that's good evidence that we were helpful in meeting this person's particular clinical goals. And with that, I'd like to thank Allison Bell, who is the neuromodulation technician and put together a bunch of this data and graphs for me. Riley King, who's the neuromodulation practitioner who did the interpretations and treatment planning for this person. And thank you all for listening. And obviously, if anyone has any questions, you can about this type of treatment or about Sierra Tucson in general, you can contact me at alex.danvers@sierratucson.com.
Okay, thank you. I've been very entertained listening to Beth and Alex, and I'm really glad all this is being incorporated into treatment programs. So what I do is that I've been looking at the brain of people that are under recovery from substance use problems and try to see how the brain recovers, and try to see, can we change the brain to look like the people that have recovered? So I'll tell you all about that. I'm an assistant professor at the University of Minnesota in the Department of Psychiatry. So I'll tell you about the current state of addiction treatment, which I'll gloss over because we've gone over already, and then how we have used neuroimaging to see how can we change the brain and identify specific brain networks that we can target to try to help people stay abstinent longer. And then I'll tell you about neuromodulation, which we have used STAR-STIM-8 to try to see how can we change the brain with that. And then I'll show you some results, exciting results that we have from our clinical trial in alcohol use disorder. So first, the current state of addiction, I'm going to go over really fast. So the main thing is that addiction is a chronic illness, like Beth mentioned. And most of the treatment programs have usually used the psychosocially based approach, where they're trying to look at the psychosocial environment and try to gear their treatment towards that. There's also been treatments with pharmacological treatment, but what we're trying to do is to target the brain. And I'll tell you more about that. So what we know from the literature is that addiction is an imbalance between 2 competing brain centers. So anybody that has an addiction, any kind of addiction, there's this competition between the decision-making center, which is the part of the brain that tells you this is the right thing to do, this is what you should do for you to be better. And then there's the pleasure center, which is farther deep in the brain. That's the part of the brain that tells you, go do something because it's going to feel good. Don't worry about the consequences. So in somebody that has an addiction, the pleasure center has won, because they have used alcohol or drugs so many times that the pleasure center, it kind of has strengthened, and the decision-making center has weakened. The decision-making center is no longer making the decisions for the person. The person is mostly being driven by that pleasure center. So what we're trying to do is strengthen that decision-making center and bring back the power for the person to make the proper decisions. So in my past research, we have been looking at, I've only did before neuroimaging research to try to see how the brain changes. Is the brain different between people that have been able to stay abstinent for a long time versus the people that keep relapsing? So we wanted to see, is there something different? Why is it that some people are able to stay abstinent and some people cannot? And that's what I'm going to tell you about first. Findings from 2 studies that I have published, where what we were trying to see is that is the brain in people that have been abstinent for a long time, in this case, in this tan bar, it's the long-term abstinent from alcohol, this group LTAA. They have been abstinent for an average of 2 years, from 2 years to 19 years of abstinence. So that group has been abstinent for a long time, a lot of people would consider them in the safe zone of recovery. There's a lot lower chance for them to go back to using. And then we have another group, the short-term abstinent from alcohol. This was all alcohol study. And in this group, people have been abstinent between 6 weeks and 15 weeks of abstinence. So these are people that are a lot more vulnerable to go back to using because they have just stopped using. And then we have a group of healthy controls here in the blue bar here. So what we wanted to see is how is the brain different between these three groups? We initially thought that people that had been abstinent for a long time, their brain would look more like healthy controls, people that don't have any substance use problem, because we would think like they have recovered, maybe their brain goes back to normal, well, in quote. But what we found was that people that have been abstinent for a long time have this network engaged a lot more than people that don't have any substance use problems. And the network is a region that is very deep in the brain. When I'm going back to this, a region here, the nucleus accumbens, that's part of the pleasure center, has high communication with a region in the decision-making center, the dorsolateral prefrontal cortex. So people that have been abstinent for a long time have those two brain regions talking to each other a lot more. That's how high this bar is, compared to those that have been abstinent for a short amount of time, and compared to those that are healthy controls. So this is these groups were like 27 people here, 23 people in this group, and 23 people here. So we can see that in average, people have been abstinent for a long time. What we call this in these papers, it's a compensatory mechanism. They have engaged this network that has allowed them to stay abstinent for a long time compared to all these other groups. And we could make that assumption because when people did tasks outside of the scanner, we got all this data from an MRI scanner. The ones that had higher communication between prefrontal cortex and the nucleus accumbens, those were the ones that performed better in tasks where they had to control their behavior. So that showed that having that network activated, those two brain regions talking to each other, was key for them to be able to perform better in the task. And we found out in these two studies. So what these two studies tell us is that having this network engaged, having the prefrontal cortex, which is the decision-making center in the brain, engaged, constantly talking to the pleasure center is important for people to be able to stay abstinent. So the next study that we did was what happens to people that are short-term abstinent, because a lot of people in this group are not going to go on to the long-term abstinent. A lot of people in this group are going to relapse. About 30–40% of people, depending on the type of drug, go back to using or not. We wanted to see, this is a second study that I'm showing here in cerebral cortex, that we were looking to see, can we predict who's going to relapse and who's not going to relapse based on how much these two brain regions are talking to each other, how much communication there is from prefrontal cortex to the nucleus accumbens. Can we predict how much the chances of somebody going back to using? So in this study, we had only short-term abstinent people, and they were either short-term abstinent from alcohol, so alcohol use disorder, or short-term abstinent from stimulant use disorder. So this was a mixed population with 69 people who were short-term abstinent. And we scanned their brains when everybody was abstinent. So at the moment that everybody was abstinent, we got this data that's here in the graph. And the data was, again, rest of MRI, like the previous one that I showed you. And everybody was about around 11 weeks of abstinence. So between 6 and 15 weeks of abstinence. So at the moment that we get the brain scan, we don't know who's going to relapse and who's not going to relapse. We follow people up for the next 6 months. So after they got their brain scan, we followed them up for the next 6 months and got their feedback and asked them, did you go back to using or did you not go back to using, and gather information around that. And based on that, we got we could classify people between those that remained abstinent over this 6-month follow-up period and the people that went back to using over that follow-up period. So now we have these two groups that we have here in the bar. So in the blue bar here, there are the 40 people that remain abstinent over the 6 months. And in the red bar, it's the 29 people that went back to using. And here, how high the bar is how strong is the communication between the prefrontal cortex in the decision-making center and the nucleus accumbens in the pleasure center of the brain. And as you can see, the people that stayed abstinent for the next 6 months showed significantly higher communication between those two brain regions. And we could predict who was going to relapse or not based on how strong the communication was. So we thought this was really exciting because it's data that we actually can predict outcomes based on how the brain is organized during early abstinence. So these two slides that I showed you are mainly observational data. So we just take pictures of the brains and see how the brain of somebody that has recovered for a long time looks like versus people that have been abstinent for a short amount of time. So all of this is observational, just taking pictures of people's brains with the MRI scan. So then the next thing was like, if we have all this information, what can we do about this? Can we change the brain so that hopefully everybody's brain has an increased communication between prefrontal and nucleus accumbens, or an increased communication between the decision-making center and the pleasure center? And this is because what I usually, when I give this talk to people in treatment programs, I usually say that the decision-making center, it's kind of like what helps you decide what to do, what helps you control behavior, like the little angel that tells you this is the right thing to do or not. And the little devil is the pleasure center. So what we're trying to do with neuromodulation is enhance the executive functioning, the decision-making center in the brain. So give the power back to that. So this is what we have been doing. I'll tell you about a clinical trial that we have completed, and we are continuing to do other clinical trials. But what we have been trying to do is to change the brain to enhance decision-making control for people with addiction. And we have chosen to use the transcranial direct current stimulation, so StarStim, because it's portable. It's something that we can bring into the treatment program. So we do this. People are in a treatment program. It's a 28-day treatment program, a residential program. And then we bring the device into the treatment program, into the same building, and administer this what we call brain training sessions. We chose it because it's portable and also because it's non-invasive and has less risks than other neuromodulation techniques such as TMS, like transcranial magnetic stimulation. So what we did was clinical trial using TDCS, where we delivered 2 milliamps to the left dorsolateral prefrontal cortex. So it's this same region here, the left dorsolateral prefrontal cortex. That's where we are stimulating. We have the anode there, and then we have a cathode on the right dorsolateral prefrontal cortex to generate that loop. And then we have, to be able to have things stable during the stimulation, we pair the stimulation with task performance. So while people get stimulation to left dorsolateral prefrontal cortex, they completed tasks in a computer. And the task that they completed was a executive functioning task, where they had to be able, they needed decision-making, working memory. And this way we could isolate the effect of TDCS, because we have two groups, a group that gets the real brain stimulation, the 2 milliamps, and a group that gets sham. So both groups did that computer task. So I'll show you more details about the clinical trial that we did. So in this clinical trial, all the participants were recruited from the same residential addiction treatment program. It was a 28-day inpatient program. We recruited about 84 participants, and we ended up with full data for 60 participants. The mean age for those 60 participants was 41 years old. 21 of them were women. And then to be able to see whether the intervention had a clinical effect, the clinical efficacy of the intervention, we followed people up after they left the treatment program for the next 4 months. So all the participants that were in the study were only alcohol use disorder participants. So then once they were recruited, participants were assigned to either active TDCS or sham. So active TDCS, like I was telling you, it's 2 milliamps to left dorsolateral prefrontal cortex. And sham, they got exactly the same setup. And they do get a very low electrical stimulation for 30 seconds at the beginning so that they kind of feel the same sensation, but then it ramps down. So that's what we had, the active versus sham, and everybody did the cognitive training task. So when people were recruited in the study, we first collected pre-intervention REST fMRI scan so that we could measure the connectivity from dorsolateral prefrontal cortex, which is the region that was stimulated, to what we call the incentive salience network. So the incentive salience network, I won't get into too much, but it's the network. This network includes nucleus accumbens, and this network is important because it's the network that makes people pay attention to things that are in their environment and go back to using. So this network has to do with craving, with anything that has to do with reward seeking for the person. So we wanted to see how much communication there was from dorsolateral prefrontal cortex to that incentive salience network. And then for 5 days, people in the treatment program, we brought the TDCS into the treatment program, and it was 5 days of getting either active TDCS or sham, depending on the group they were randomly assigned to. And they did this twice a day. So in total, they had 10 days of TDC, 10 sessions of TDCS over 5 days. And this is a schematic of the task that we did. It's called a reversal learning task, where participants need to learn what is the rule, the rule for the correct response. And after some time, they continue using that same rule. After some time, that rule changes, and then they have to adapt and figure out what's the new rule that now works. And we thought this was a task that applies to people that have an addiction, because that's what people with an addiction, something works for them. At the beginning, using alcohol or drugs it feels good, it works for them. But after some time, things change. It's not good anymore for them. They realize they need to stop. And then they have to adapt their response to those cues that makes them go back to using. So we did this task. Everybody completed this task while they were doing receiving their brain stimulation. And then after those 5 days of TDCS, of brain training, we collected again REST fMRI data. So we call this the post-intervention REST fMRI, and we measured the change of the connectivity between prefrontal cortex and incentive salience here, and prefrontal cortex and incentive salience here. And all this was done while participants were patients in the treatment program. And then after they left the treatment program, we followed patients up over the next 4 months. And we would call them every month to ask, did you go back to using or not? And we did all kinds of surveys and gather information around use if they did. So from this clinical trial, we had 2 main measurements. I'll focus on these 2 main measurements. We had others too, but we looked at the effect of the intervention on treatment outcome over the 4 months. We wanted to see whether somebody relapsed, yes or no, over those 4 months. And then we also wanted to see whether we changed the brain. So we looked at connectivity change. So connectivity from the prefrontal cortex to the pleasure center, the incentive salience network of the brain. And we tried to see how things change from before doing the intervention to after. And then we contrasted that between the group that got the real brain stimulation versus the group that got the sham. This is first the result on the outcome. So the binary relapse outcome. So here on the x-axis, we have people, the two groups, active TDCS. There were 31 people that were assigned to active TDCS. And then there were 29 people that were assigned to sham. And then this is how many people are in each bar, the y-axis. And then here we have the people that remained abstinent over the first month. This is only up to 1 month after they left the treatment program. So 23 people remained abstinent in the group that got active TDCS, and 17 people remained abstinent in the group of sham. But the part that we wanted to focus more is the percentage of people that relapse. So people in the active group, only 11% of the people in the active group relapsed. And 3 times more, 35% of people in the sham group relapsed here. So from this intervention in our paper here, we say that we lowered the chances of relapsing. In this case, threefold, we lowered the chances of relapsing. So if somebody got the intervention, the real brain stimulation, they were 3 times less likely to relapse compared to people that got sham. So we are now conducting a larger clinical trial because the sample size here is small. And we're trying to see if these effects are still showing with a larger sample. Another thing is that this data here, it's out to 1 month. When we looked at the data all the way to the 4-month follow-up that we did, this effect washed out. So it's very similar to what Alex was saying, like people are asking how many sessions do we need? So this 5 days of TDCS seem to have an effect only out to 1 month, but then that effect washes out after 1 month. So those are important things that we have been trying to address in the new clinical trials that we're doing now. But this finding is really exciting and promising, showing that having active TDCS in this controlled clinical trial, people that did not get the stimulation were 3 times more likely to relapse. And then when we look at the brain, here we have in the x-axis is the measure of how much the connectivity between left dorsolateral prefrontal cortex, left because that's the part that we stimulated, the connectivity from left dorsolateral prefrontal cortex to the incentive salience before. This is corrected for baseline. And then this is post, after the intervention, that same measure. And then how high the value here is, how much stronger or less strong the connectivity between prefrontal and incentive salience network is. So as you can see here, people that got active TDCS, their connectivity, so the communication between prefrontal cortex and the incentive salience network increased. Compared to the people that got sham, the connectivity decreased from pre to post. So we actually are showing the previous slide as the clinical effects of TDCS, and here we're showing the effects on the brain of TDCS. So we are showing that we can change the brain with this intervention of 5 days. And again, this is while people are in the treatment program, and we did not collect data after they left. So if we look at the data in a different way, here we have the people now, instead of splitting it by what intervention they got, what group they were randomly assigned to, this is splitting the people by whether they stayed abstinent or they went back to using. But it's the same group of people. So the people that remained abstinent, regardless of their intervention, those are the ones that showed an increase in connectivity from prefrontal to incentive salience, and the people that went back to using have a slight decrease. So this is a significant group by time interaction. So this shows that it's a piece of evidence showing that it's important to have increased connectivity between the prefrontal and incentive salience, because those are the people the ones that showed that increase are the people that remained abstinent after being discharged from the treatment program. So we think that this is really exciting findings. We're now continuing to do more clinical trials, doing this very similar setup in the clinical in the clinics, in patient clinics, the same clinic that we're recruiting the patient. And these are the people that collaborated with me, funding that I have, and the lab that I have that helped me do all this data collection. And I have my email here for questions.
Thank you so much, Jazmin. Appreciate it. So now to top things off, we're just going to have a panel discussion. I know we could probably spend a few more hours, talking more about, the follow-up from the presentations. But I'd like to start just out of curiosity. I mean, I love what all of you are doing. I especially think, taking that brain map as the initial step, I feel is so important. And I feel, even, not just with addiction, but with mental health. I'm just curious. We'll start with Alex, because that's your Sierra Tucson is doing that right now. What would you say of all the patients that you treat? What percentage actually start with the brain map? And is that subject to insurance? Like, I don't know how all that works. So yeah.
Yeah, I was ready for this question, so I did a little back of the envelope calculation this morning. We probably do about a dozen brain maps a week. In a given month, we probably have 140 to 150 people. So that puts us at like 32% of our people are ending up with brain maps. As I mentioned, in the way that we organize our treatment, we're kind of an adjunct to kind of what we think of as like typical treatment. There's a psychiatrist who tries to figure out what the right medication combination is. There's a therapist who tries to come up with a good approach. We have extra testing through clinical psychologists, and probably that's the department where we have the most crosstalk, probably because of me, because I'm a psychologist with a PhD. And so our staff, our neuro staff talks to our clinical psychology staff sometimes when there are questions about what symptoms are going on, or maybe to help that clinical psychologist inform their diagnosis. What I would say right now, and what I don't want to represent Sierra Tucson is doing, is saying, hey, our clinical decisions are made based on a brain map. I think we're probably a little bit a ways from doing that, but I think we're very close to a place where we could say, hey, this is extra information that a clinician can use to make their decisions.
Exactly. Yeah. Thank you so much. And Jazmin, with your study, and I know you used sort of fMRI as a marker, have you considered using EEG as a marker sort of before and after stimulation, or even to track sort of recovery in patients?
Yeah. We have the system that can collect EEG, but all of our previous the previous data that I showed, it's all with fMRI. So we wanted to keep that consistency to see if what we had measured before, are we seeing the changes the same? But we do have the system, and we have been thinking about doing something very similar to what Alex showed, which I thought really exciting.
Yeah, and so just in terms of all the different sort of applications that you have at Sierra Tucson, how do you make a decision? Like, is it trial and error, or is it something you see on the brain map? I know that's probably a combination of various factors, but yeah, so how do you go about making decisions on the treatment plan?
Yeah, so again, I'm gonna emphasize that we're kind of at a place where we're trying to get more communication. The therapist builds a treatment plan based on standard psychometric assessments, and we decide what applied neuroscience treatments to give somebody based on the QEEG brain map. And in the past, it has been kind of like a sampling platter. We say, hey, this is what it's showing up. It's showing up that you've got attention and memory problems. Is that what you want to deal with? But sometimes, and everybody working in mental health knows there's tons of comorbidities. It'll be like, well, no, actually, I'm very anxious. So, well, okay, maybe biofeedback, heart rate variability, some breath training is a good place to start. So we allow a little bit of client direction.
Excellent. Yeah, thank you. And then, so Jasmine, I was curious, and this might be, I don't know if this is even measurable, but just in terms of, because we know underneath sort of, most addictions, as kind of Beth alluded to, is there's kind of an underlying, mental health condition. Of course, addiction itself is a mental health condition, but there tends to be sort of associations with, childhood trauma and other issues. So when you're doing this sort of the stimulation protocol, is there any way to measure, so we know that it kind of reduces relapses, which is amazing, right? But do we know, like, if it's helping with the mental health condition? Like, I don't know, like, is there any, like, I don't even know how you would measure that, like, in terms of even
So
speaking.
yeah, we actually did measure. We administered BDI, the Beck Depression Inventory and Anxiety Inventories. We also administered craving measures before and after.
Okay.
And all of them, for both groups, for the active and sham, they drop, but the drop is not different between groups, between the ones that got the real brain stimulation or versus not. So for depression and anxiety, we did not see that the 5 days of TDCS have an effect in decreasing. There was a significant decrease in depression and anxiety, but that's mainly, I think, because of the treatment program rather than our intervention, because active and sham did not have any difference. And I'm going back to the other question, is that another reason to use fMRI is that fMRI allows us to have better high resolution of deep brain regions that have to do with depression, anxiety, like amygdala, and also nucleus accumbens, all the limbic regions that are in the pleasure center of the brain. We are able to collect better resolution with fMRI and with EEG, but it's like a source localization and a lot of calculations needed to do that.
Right. Yeah, it's just that sort of the EEG, I think you can't beat it for temporal resolution. So in terms of like timing to see like different brain areas, like in that correlation would be interesting to kind of to look at that as well. And if I were to ask sort of all of you, if you could change anything in the field, and I know there's probably a long list, right? But like what type of things, come to mind? If you could have like a magic wand and say like, and I know that's
Beth,
there's probably a lot to unravel there, but
yeah, I mean, I think I spoke heavily about the stigma of substance use, and I think that's the biggest thing that we're still combating, because that ends up becoming very internalized by the patients, which causes them to wait longer before seeking treatment. It causes them to be more isolative with their behaviors. And then, of course, depending on who they encounter first in the provider world, they may or may not be feeling a sense of, being validated in their experience, understanding that it's a medical disease and not a judgment on them. So like I said, we still have a very large divergence in how our providers even look at these patients. And so that causes a big problem. Additionally, like it's sort of a hidden population because they keep themselves a little bit hidden. So there tends to be less funding and less sort of focus on it. Like I said, right now we're seeing more focus on the adolescent and young adult component, but there needs to be a lot more research on what will be helpful. There needs to be a lot more discussion about these individuals as patients, as opposed to the way we look at them now, which is a lot of people look at it as criminals, as opposed to patients, and that's hugely problematic.
right. Thank you so much. Yeah.
Piggybacking on what you said, Beth, is also the reason why we had 5 days. It's because that's how much we can fit during the 28 days. So it would be so nice that the treatment programs would be longer, not just because of for our purposes, but chances of people staying abstinent increase if the treatment programs were longer. And that's something that here it's 28 days, what the insurance covers, and I think at some point they also cut it down to 21 days here in Minnesota. And then they realized and went back to 28 days. So all those resources that need to be dedicated and also for the laws to approve, like, yes, insurance should cover this many days for somebody to be in a treatment program. And that would allow more, brain stimulation days too.
We work with insurances that only will allow, between 8 and 14 days, which is just ridiculous. I mean, there's nothing you can do in that amount of time that will really, other than detox, which isn't really full treatment.
And it's so unfortunate. I mean, if we came back with the data, and I think our RCA has done this or is doing this, like to report back like the times that people have to repeat in treatment, that they would actually save money if they just, had them go for a longer period of time. Is it a matter, because I think unless you work in the field, you might not know, like the brain physically changes when somebody has an addiction, and that takes a long time. I mean, it takes at least a year usually, or more, like for the brain to kind of
I think
heal.
this goes back to that idea about stigma is, that this is a population that doesn't have a whole lot of people advocating for them. This is a population that cannot really advocate for itself. And people who will stand up and sort of say, I want to help these people. It's a few and far between group. And so that can be hard to advocate for those changes to occur because it's such a hidden population.
Yeah, and I think that's a great point. So if I were to ask, if we were to ask kind of in general, is it something that, fellow researchers or clinicians or even just citizens can do, like maybe, reaching out to their elected officials, right? And, because every little bit helps. And I think the more people that are aware, the more active, people can become. And I think, elected officials hearing from more and more people. I mean, unfortunately, that's how things happen. I say unfortunately, because it takes a lot of effort, right? And I think unless you're in the field, it might not be something that you're aware of, right? So I guess, I don't want to take up too much more of people's time, but just kind of maybe as an ending note, like maybe talk a little bit about the next steps in what you're working on and things you'd like to see happen, like in your, environment of where you are.
Yeah, I mean, I think in some ways this presentation was really a way of me sort of sharing what I'm hoping develops more in the coming year. I'd like to see treatments like TDCS and neurofeedback folded more into standard care and better integrated with other elements of care. And I'm really happy to be part of this because, you get to see the good work that's being done kind of like from the clinic to the lab. And thanks, Jazmin, for sharing all your great work. I'm sure I'll be talking to my colleagues about this as I make the case for increasing our neuro department.
Yeah, I think for us, we're constantly looking for these new and innovative ways to treat. Unfortunately, looking at the statistics, we're kind of fighting a losing battle. And so we need some more artillery for what it is that we're gonna throw at addiction to figure it out. So I'm really excited that I was here and got to hear both of these very innovative individuals. At RCA, we try to use holistic medicine. We try to sort of touch on a variety of different things, but more resources are better because what works for one doesn't always work for another.
And just to kind of just to emphasize, I mean, that is so important, the holistic aspect as well. So even, I know the RCA, does a lot of holistic, like even like a nature walk, and just to see how that can be so transformative. And I know the Sierra Tucson also does the sort of the adventure therapy, and that's huge. And so things that, I think people might not stop and think about, and I know that they've had, miniature horses come through the RCA, and that's so therapeutic, going out for a walk, feeding birds, and it's just amazing. So I just, thanks to all of you and the work that you're doing. And Jazmin, what about
The near future is we're trying to figure out the best dose. So the previous one was 5 days, and so now I'm doing a trial where we're comparing 5 versus 10 days, which is 10 is like we can barely fit it within the time that people are in the treatment program, to see, can we see effects farther out from 1 month, like I was showing you, does it last longer? And I'm also applying for funds to also do a trial instead of TDCS to use TACS, alternating current, because there's some evidence out there that has a stronger effect with less days and maybe more durable. So we want to compare and see, can we, the goal is to make things more, increase efficacy and durability of the intervention that we have seen these nice results so far. And on the other part is, because people leave the treatment program, we're also thinking about how to deliver these remotely, which we have started in other people that I collaborate with. They're already doing some remote administration of TDCS, and but those are still ongoing. So we're still collecting the data. But yeah, the goal is to make this more available to more people and make sure it works both clinically and changes the brain with like durability too.
Right.
So yeah.
And it's probably too early to know whether or not this becomes sort of reversible in a person's brain, or is it something that would need sort of maintenance, like once a month? It's probably too early, it sounds like, because this is just sort of, yeah.
So far, like the data I showed in the very first graph is that people have been abstinent for a long time, an average of 7 years. Their brain does not go back to looking like a normal brain, does not normalize. So it's like a constant, what from anecdotally, the participants that we have, there's like, they say that they constantly have to be vigilant. So the rest of their lives, they have to have that compensate, whatever helps them stay abstinent, and they have to have that engaged for the rest of their lives. So that's the other thing, like what Alex was saying, that maybe we need to have boosters or more sessions to be able to have the effects of whatever intervention we're doing to last longer.
Yeah, thank you so much.
No, I think it's fascinating. Thank you, Beth, Jazmin, and Alex. I think it's been great. Thank you for the wonderful work. And we really hope that all your great insights will really help down the line patients and help improve the lives. And at NeuroTech, we'll be sure we do our part to support your efforts. So I can only thank you and wish you continuous success and keep on working as hard as you're doing now.
All right, well, thanks again, everyone, for your time and information. It was just enormously fascinating and interesting. And so be on the lookout for our talk this spring, EEG as biomarkers. And we look forward to next time. Thanks, everyone, for joining us.
Thank you. Bye-bye. Bye-bye.